Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. I have received several requests to have topics focused on gastrointestinal imaging and a specific recent request for a dedicated episode on liver lesions. Creating a dedicated episode on liver lesions has been on my mind for some time, and I appreciate the opportunity to present a question and answer episode on liver lesions. One quick aside, I recently became aware that the American Board of Surgery recently attempted their first online virtual 2020 general surgery qualifying exam, and things did not go as expected. It may be worth your time to read quickly the section on antmini.com in the resident forum on the American Board of Surgery board exam, and you can also find a frequently asked question page on the American Board of Surgery website that discussed what happened during their first attempt at a virtual examination. As a spoiler alert, things did not go as planned. I will post a link to that American Board of Surgery website page in the show notes for this podcast. And I, along with you, hope the best for all residents and certifying bodies who are trying to navigate this new situation. My sincere hope is that you will get the board examination experience that you deserve that is fair, safe, and reliable. That being said, let's get into the topic for this episode, which is liver lesions. I will start by discussing predominantly CT, MRI, and nuclear medicine imaging manifestations for common liver lesions. On a future episode, I will cover interventional radiology therapies for liver lesions. All of these topics I do consider to be high yield for the ABR core exam. Let's get into the first question. Hepatocellular carcinoma develops along a spectrum. Describe the spectrum of hepatocellular carcinoma development, including some imaging manifestations. To be brief, I will abbreviate hepatocellular carcinoma as HCC going forward. Can you describe the spectrum of HCC development? The answer that I'm looking for is that HCC starts with regenerative nodules that may progress to dysplastic nodules and then to hepatocellular carcinoma. Whether this is a mandatory sequence of progression, I am unclear, but we do need to be aware of the imaging appearance of regenerative nodules, dysplastic nodules, and HCC in the liver. Key imaging manifestations are that dysplastic nodules tend to be dark on T2 weighted images, and hepatocellular carcinomas tend to be bright on T2 weighted images. Regenerative nodules may be bright or dark on T2 weighted images, and importantly, regenerative nodules typically do not enhance or wash out differently than normal liver. The reason for this is that regenerative nodules are composed of normal liver cells. Dysplastic nodules may have arterial enhancement above that of liver, but do not demonstrate washout. An absolute key that I hope you already know, or that you will at least know after this episode of the podcast, is that hepatocellular carcinoma demonstrates early arterial enhancement and washout on delayed post-contrast images. Key imaging manifestations for HCC is a T2 bright mass or masses with arterial enhancement and delayed washout, with coexisting findings of cirrhosis. This is so important, I will repeat it one more time. Key imaging manifestations for HCC is a T2 bright mass with arterial enhancement and delayed washout, with coexisting findings of cirrhosis and portal hypertension. Next question. What are some of the common risk factors for development of hepatocellular carcinoma? Risk factors for HCC include cirrhosis of any cause, including chronic hepatitis B and hepatitis C. Now, interestingly, I have read that acute hepatitis B is a risk factor for HCC even without cirrhosis. Other risk factors include hemochromatosis, and in fact, hepatocellular carcinoma accounts for about 1/3 of deaths in hemochromatosis patients. Other risk factors are glycogen storage disease, such as von Gierke's disease, alpha-1 antitrypsin deficiency, and other entities such as Budd-Chiari syndrome. That is not an all-inclusive list, but it does cover many of the leading causes of HCC. Next question. True or false? Most patients with HCC will have an elevated alpha-fetoprotein level. What do you think? Do most HCC patients have an elevated AFP level? The answer is true. In fact, up to 95% of HCC patients will be expected to have elevated AFP levels. Next question. What are imaging manifestations for the fibrolamellar HCC variant that you should look for on board exams? Again, what are imaging manifestations for fibrolamellar HCC? That is FIBROLAMELLAR, fibrolamellar HCC. If you haven't heard of this yet, you need to be aware of this. The answer is that typical features of fibrolamellar hepatocellular carcinoma: a central non-enhancing T2 dark scar on MRI. The central scar may be calcified on CT. Additionally, fibrolamellar HCC tends to develop in patients younger than 35 years without cirrhosis and with normal AFP levels. Fibrolamellar HCCs are aggressive, so they may also show you local nodal or distant metastatic disease. There are important differences between garden variety HCC and fibrolamellar HCC that you need to be aware of. To review, the patient demographic is very different. For fibrolamellar HCC, you are looking for a young adult, typically less than 35 years of age, without cirrhosis. Hepatocellular carcinoma, classic variety, almost always develops in a patient with cirrhosis. Fibrolamellar HCC does not typically have cirrhosis. Also, AFP levels may be normal for fibrolamellar HCC, and as I told you, for typical HCC, up to 95% of patients would have an elevated AFP level. Also of note, fibrolamellar HCCs are more aggressive, so keep that in mind. Next question. If you see a hepatic mass with a central scar demonstrating delayed enhancement on MRI, what hepatic lesion is this typical for? One more time, a hepatic mass with a central scar that demonstrates delayed enhancement. Now, I told you that fibrolamellar HCC has a central non-enhancing scar. So what if you have a central scar that shows delayed enhancement? The answer I am getting at is that, although somewhat nonspecific, for board exams, you need to keep in mind that a mass with a central scar and delayed enhancement is characteristic for focal nodular hyperplasia. And throughout this episode, I may abbreviate focal nodular hyperplasia as FNH. Next question. What are other imaging manifestations of focal nodular hyperplasia on MRI? The answer is that focal nodular hyperplasia presents with a spoken wheel or cut grapefruit appearance. On post-contrast imaging, FNH has also been termed a stealth lesion because without contrast, meaning on pre-contrast T1 and T2 weighted images, it is commonly iso-intense to liver. So it is stealthy without contrast, and then you give contrast, and you see the spoke wheel or cut grapefruit appearance. With gadolinium arterial enhanced images, you often see a cut grapefruit appearance due to enhancement of the mass surrounding the non-enhancing scar centrally that has radiating bands. On delayed post-contrast images, the central scar will classically show delayed enhancement. Most common clinical history would be a mass in a middle-aged woman. FNHs may regress on their own with age, and note that FNHs do not demonstrate washout of contrast as in hepatocellular carcinoma. That is very important. FNHs can have arterial enhancement but do not show washout. However, you may see less enhancement on delayed post-contrast images than you do on arterial enhanced images. What washout means is that on delayed post-contrast images, the mass lesion itself enhances less than the normal background liver. Okay, if the mass enhances equal to the background liver, I do not think of that as washout as an HCC. With a hepatocellular carcinoma, it will show arterial enhancement above liver and washout of enhancement to levels below normal liver on your delayed gadolinium post-contrast images, or on a triple phase CT, the same principle would apply. Next question. What nuclear medicine scan should you remember for FNH diagnosis on board exams? Now, for all of these nuclear agents, they can show different types of uptake with different tracers, but a few are classic, and those are the ones I will cover in this episode. So for focal nodular hyperplasia, for board exams, I would remember that FNH can show uptake on a sulfur colloid liver scan. And FNH has normal hepatocytes around abnormally arranged ducts and Kupffer cells. As the lesion contains normally functioning reticuloendothelial system cells, you would expect that the RES would show sulfur colloid uptake. Other hepatic masses, such as a hepatic adenoma, hepatocellular carcinoma, or hepatic metastases, do not have functioning Kupffer cells and therefore will not have uptake on sulfur colloid. So very important to remember, FNH, look for uptake on a sulfur colloid scan. Other hepatic masses, you do not expect uptake with sulfur colloid. That is a generalization, but I think it will serve you well on board exams. Next question. If a board exam question shows you a liver lesion and gives you a clinical history of a woman on oral contraceptives, what lesion should you think of first? In other words, what hepatic lesion is most associated with oral contraceptive use? The answer, I am hoping you know, is that a liver lesion with a provided clinical history of oral contraceptive use should make you consider a hepatic adenoma as the most likely diagnosis. An alternative history that they can present on a board exam for a hepatic adenoma is a male patient on anabolic steroids with a liver mass. So if you see any question showing a liver mass with an additional history of either oral contraceptive use or anabolic steroid use, a hepatic adenoma should be high on your differential. Because hepatic adenomas are classically hormonally induced, at least on board exams, and because of that hormonal influence, you also are more likely to see hepatic adenomas in a patient who is obese due to the elevated estrogen levels. Next question. What is the imaging appearance of a hepatic adenoma? I told you that hepatic adenomas are frequently associated in individuals with oral contraceptive or anabolic steroid use or obesity, but how do they look on imaging? Most commonly, hepatic adenomas present as a solitary mass, which may be large, and these are most common in the right hepatic lobe. If you see multiple hepatic adenomas, you can consider entities like glycogen storage disease as an underlying factor. Hepatic adenomas classically contain either or both of internal fat or hemorrhage. As a reminder on board exams, if you see a lesion with sulfur colloid uptake, think FNH instead of hepatic adenoma. Hepatic adenomas would not be expected to have sulfur colloid uptake because these do not have functioning Kupffer cells. On MRI, hepatic adenomas would classically show internal fat that is manifested by signal dropout within the lesion on out-of-phase images compared to in-phase images. You also would expect to see some early arterial enhancement and a return to normal liver enhancement levels on delayed post-contrast images. A return to normal liver enhancement on post-contrast images does not meet criteria for washout for hepatocellular carcinoma. With HCCs on delayed post-contrast images, the mass will enhance less than the normal liver. With hepatic adenomas, you may see some arterial enhancement, but no washout. Next question. What is the common clinical management of hepatic adenomas, And what is a risk of hepatic adenoma that you should be aware of? These two questions are tied together, the risk of hepatic adenoma and therefore how do you manage them. The first step is to stop hormonal stimulation, which means stopping oral contraceptive or steroid use, and then you reimage after a short interval. If a hepatic adenoma is less than 5 centimeters in size on your follow-up imaging, for board exams, I think you should select that you recommend imaging surveillance instead of surgical removal because it will likely continue to regress and it is already smaller in size. If a hepatic adenoma is greater than 5 centimeters in size on follow-up, this has a bleeding risk. Okay, that is the risk I was getting at with hepatic adenomas. And also a rare cancer risk for development of hepatocellular carcinomas. So for board exam purposes, you should select that you would resect hepatic adenomas that are greater than about 5 centimeters in size. The reason for the bleeding risk is that hepatic adenomas are thought to have poor internal connective tissue support. Therefore, the larger lesions are poorly supported internally and are therefore prone to internal trauma and hemorrhage. If a patient with a hepatic adenoma does experience this intralesional hemorrhage, they can experience acute pain, and in some cases, if they have brisk bleeding, you can develop serious internal abdominal hemorrhage. Next question. What are similarities and differences of HCC and hepatic adenomas on imaging? I've already covered some of this, so let's see if you were paying attention. Similarities include hepatic lesions that may contain fat, and both can be well circumscribed. I don't think I mentioned previously that an HCC can contain internal fat, but it can, although I think internal fat, at least in my mind, is more classic for hepatic adenoma. Differences between an HCC and hepatic adenoma include a typically homogeneous post-contrast appearance of an adenoma versus a typically more heterogeneous appearance of an HCC. Both lesions can demonstrate arterial enhancement, but only HCCs classically show washout on delayed post-contrast images. If you have chronic liver disease and a mass containing internal fat, it is a hepatocellular carcinoma and not an adenoma on board exams. I think that rule will serve you well. If they show you a liver lesion and you can clearly see cirrhosis, that will be HCC and not a benign liver mass such as an adenoma. What is the classic nuclear medicine appearance of a hepatic adenoma versus focal nodular hyperplasia on a technetium sulfur colloid scan? I'm beating this to death, but FNH will show uptake on technetium sulfur colloid because it has functioning Kupffer cells. Hepatic adenomas have poorly functioning or dysfunctional Kupffer cells, so these would classically not show uptake and may even appear photopenic compared to liver on a technetium sulfur colloid scan. Next, what is the imaging appearance of a hepatic hemangioma on CT or MRI? Very important to know this. What do hepatic hemangiomas look like on CT or MRI? On MRI, hepatic hemangiomas are T2 bright masses, and when I say T2 bright, I mean as bright as cerebral spinal fluid bright, so very T2 bright masses. On CT, hepatic hemangiomas are typically hypodense lesions that can look very similar to a cyst. On both CT and MRI, hemangiomas show peripheral interrupted nodular enhancement with a progressive fill-in of central enhancement on delayed enhanced images. Of note, because blood flow is slow and blood pools within hepatic hemangiomas hold on to the contrast for a long time and may actually enhance for about a half hour following contrast administration. To drive this home, the classic appearance for a hepatic hemangioma is peripheral nodular interrupted enhancement with progressive filling in of contrast on more delayed post-contrast sequences. Really large hemangiomas can look very heterogeneous because they can have venous pooling, and that venous pooling can even cause venous lakes and central blood clots, and all of that can cause a heterogeneous appearance, especially on T2 weighted images. Next question, what is the ultrasound appearance of a hepatic hemangioma? Now, in general, I think ultrasound appearances for these hepatic masses are somewhat less important, and particularly less important for HCC, because there really are no specific imaging findings for HCC. Although if you see a cirrhotic liver and a mass on ultrasound, I would be highly suspicious for hepatocellular carcinoma. For a hepatic hemangioma on ultrasound, you would expect a well-defined, uniformly hyperechoic lesion, that's HYPER, hyperechoic lesion. Surprisingly, there is typically no visible Doppler blood flow identified, as the blood flow within a hepatic hemangioma is slow and is often too slow to be identified by Doppler ultrasound imaging. Next, uptake with what nuclear medicine study is most typical for hepatic hemangiomas on board exams? The answer is a tagged red blood cell scan. If you see a liver mass showing uptake on a tagged red blood cell nuclear medicine study, think hepatic hemangioma. I remember this because hemangioma has the hemangio in the name, and that should make you think of vascularity and blood flow, as in a tagged red blood cell study. If you also remember that hepatic hemangiomas have slow blood flow and that blood can pool within the hepatic hemangioma, it makes perfect sense that if you inject tagged red blood cells, these would also pool within the lesion and be retained within the lesion because of that very slow blood flow, and you would therefore see uptake within the lesion on a nuclear medicine tagged red blood cell scan. That is enough for now. I will continue the discussion on liver masses on the next episode. Thank you for tuning in. Study hard, prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.